Hello, everybody. This is Deb Motes. I'm here to be the facilitator for the presentation today. It's 12:30 Central Time, so we're going to go ahead and get started. Welcome to our third webinar of the 2022 Stroke Education Series, Telestroke Spoke Hub, using data to drive quality outcomes. My name is Deb Motes, and I'll be your moderator for today. Feel free to ask questions throughout the presentation by typing them in the chat box on the right side of your screen, pressing the microphone at the bottom of your screen, or using your phone audio press *6 to come off mute. Before we get started, I need to provide the following disclaimer. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The American Stroke Association does not endorse any product. So Dr. Rasmussen will be pulling up her presentation while I introduce her. So let me stop sharing mine. Okay. So while I'm introducing her, our speaker today is Jennifer Rasmussen-Winkler. Dr. Rasmussen-Winkler is a fellowship-trained neurologist. She is board certified in neurology and vascular neurology. Dr. Rasmussen is the chief of neurology at Baylor University Medical Center in Dallas, the system telestroke and neurohospitalist director for Baylor Scott and White Health, the system, and the director of the neurohospitalist group, Baylor University Medical Center. She oversees currently a 26 hospital network and provides telestroke services in the area she serves. She is currently a fellow at the American Heart Association and has participated in several AHA conferences over the last few years. During the development of the Baylor Scott and White Stroke Program, she increased stroke admissions from 732 to 1,500 and increased TPA utilization from 7 to 12%. And that was in 2014-2015. She initiated the Stroke Alert nurse activation with a relative reduction of stroke mortality by 50% in 2016. Between 2017 and 2019, she developed a Spoke Hub telestroke module and rolled it out to 14 hospitals across the Baylor Scott and White system, which ended up resulting in a reduced door-to-needle median of 45 minutes in each of the facilities, utilizing telestroke within that first year. She has participated in several multi-center research trials, has authored several publications, and several poster abstraction presentations. Her passion for serving stroke patients in Texas is evident, and she serves all people by providing personalized health and wellness through the exemplary care, education, and research. And I've had the great opportunity to work with Dr. Rasmussen since I started in stroke in Texas back in 2010. So it is my privilege to now turn over the presentation to Dr. Jennifer Rasmussen-Winkler. Dr. Rasmussen?
Thank you, Deb. What a sweet introduction. I really appreciate it. I'm intimidated by what you had to say. Everyone, thank you so much for your interest in a topic that is near and dear to my heart, which is telestroke, and how do we implement systems of care and create systems of care where we take evidence and research and turn it into processes. I have nothing to disclose. I don't have any financial obligations that I receive outside of my employment for Baylor Scott and White. This data that we're going to present, some of it is proprietary to Baylor Scott and White, so I am approved to share it with you for the purpose of education, but please do not share beyond education. So we'll start by just the basics, talking about stroke burden. We still have close to 800,000 strokes experienced a year, with the majority of them being first-time strokes. We've reduced stroke incidence with treatments of blood pressure and all of our secondary and primary prevention options, but it still remains a top cause of disability. And with that disability comes high care. And what I think we're going to see over the next 10 to 15 years is even more cost of disability, both direct and indirect, as our stroke population has become younger. So treating stroke, reducing disability, I think is the core of what we see in stroke care and what really the goals are of what we're doing with these systems. For a little background on the history of telestroke, it was actually first brought up and thought of alongside with the NINDS trial. As we were able to prove that time mattered and TPA was effective, it became clear that to treat all of our patients equally, be it in rural facilities, in urban, suburban areas, we didn't have enough neurologists to do that. And so the need for some sort of telestroke coverage was identified very early on. Facilities and evidence started coming out that there was a need for feasibility. How did we make it feasible? We had tons of connectivity issues. How do you get cameras into the right places? How do you work through a lot of these issues that we still have today? In 2014, Dr. Wu's group was able to show that 4G improved connectivity, and he could put telestroke into the mobile stroke unit. After demonstrating that it was feasible and reliable, he did an excellent study in 2017 that actually showed it was equivalent care to being in person. I think this piece of evidence is vital when we go out and we talk about stroke and telestroke and what are the differences of in-person neurologist versus virtual. If we can get the same quality of care and faster with having somebody virtual versus having somebody in person, this study really helps make that argument and helps us talk to leaders as we roll out processes. Telestroke benefits, overall as a nation, we have a shortage of neurologists and it's getting worse, not better. Along with our shortage of neurologists, we have an increase in stroke burden, we have an increase in neurologic disease burden, and a need to be able to provide care. As telestroke and stroke grows, to give that same quality of care at every site, there just aren't enough people to be able to do that. So it's important to look at how do we share that resource. We've been able to prove that neurologists who are stroke trained improve your treatment times, improve the safety and compliance, reduce mimic treatment, improve unnecessary or reduce unnecessary transfers as well. And with telestroke, you can make that expertise available at small centers, available in our rural facilities, and really start to create that standardization of care across the nation. This was taken to the federal level, and in 2018, CMS actually supported the FAST Act, which waived for telestroke. Remember, all this is pre-COVID, before our COVID emergency, but it waived the need for you to be in a rural or critical access center to do telestroke and get reimbursement from CMS. It actually made it legal and supported to do it at any facility in the emergency room because it increased your access to care and the timeliness of care. And we also had evidence that it didn't reduce efficacy of care. And then you're allowed to bill for it to get the facility cost back. So the cost for your technology at the spoke facility is approved to be reimbursed through CMS if you drop the appropriate code. So this really changed our view of, could we even implement it? I know in Texas, it made a really big deal for us as well, because initially when we looked at this, there was always concern of, is it a rural area? Is it a critical access area? How are we being compliant? You can see that this is really rolled out across the nation. When in 2011, when they looked at US population, having access to a facility that could treat you with TPA within 60 minutes of where you lived, only 80% of the population had access. And by 2019, with the approval of telestroke, the increased access to telestroke, it improved to 96% of our US population having access to acute stroke treatment within 60 minutes of where they live. And that's groundbreaking to me. Those are patients that a lot of times are not part of our care system, are at higher risk for stroke and higher risk of mortality from stroke. And we can now give them access, again, that standardization across the nation. So for Telestroke, there are two main models that get discussed. One is a spoken hub model, and that's where you have a central comprehensive stroke center and a stroke neurologist that through telemedicine gives protocols, gives advice, and does a telemedicine assessment at all of their spoke sites with the intent of transferring in the complex strokes and leaving at the center the non-complex. You also have hubless models, which are more of the privatized section of Telestroke, where it's a group that the ED contracts to come in and give transfer care, but they aren't integrated with, or not transfer care, I'm sorry, stroke care, but they aren't integrated with the whole transfer process for the system or where to go or knowing the ins and outs of how that system works typically. For the purpose of this lecture, we're going to focus more on spoken hub model because that's our experience. And so now we'll go through kind of what did Baylor, Scott, and White do and why. And we are a spoken hub model that has evolved over the last 5 years and now has a wide range of who we cover. Started initially in Temple, Texas as our first Joint Commission Comprehensive Stroke Center, which is a mixed rule for those of you that don't know. Temple is just about an hour north of Austin. It's a mix of rural and suburban care. It's definitely not in a metroplex, it's got Austin just south of it. But the amount of coverage of who transfers in there is quite large. It's about the size of it's about 3 times the size of the state of New Jersey, just to give you perspective on like the volume of area that we're covering. And a lot of those areas are rural areas that don't have access to care or aren't part of a bigger network of care. And so as we saw this, we wanted to start working within our own system of how did we improve these communications? How did we develop Telestroke out there and start treating patients and bringing them into our comprehensive center as needed? So the foundation of it, as we said earlier, the issue as Telestroke was being developed on a national level is how do you actually get a device? What device do you choose? What's the best way to approach it? So you have to have something that's HIPAA compliant. You then have to be able to access it from a cell phone or a laptop 24/7. Initially, a lot of my administrators wanted it to be compliant through a computer, and we hired a neurologist to just sit in-house at a computer and be available for Telestroke. And I don't know how many of you are neurologists on this call or not, but no one wants to be at night or weekend sitting around waiting for a call. And so one of the things that we really looked at is how can you have it to where you can have rapid, quick access wherever that neurologist is, whether they're in their car driving to pick up their kid from school or drop their kid off, whether they're, driving home from the office, whether they're at home, whether they're in the office, they had to have good access for it. The other issue we had was, like I said, HIPAA compliance, which FaceTime didn't meet that requirement. It was one of our first goes with it. Also connectivity. So we had several robots, and this assessment that we did to choose what we went with was in 2016, 2017. So it's changed and we're probably due for a new assessment, but several of the robots actually delayed in how they moved in our facility. And that delay, when we tested them out, led to one accidentally hit a nurse. Like it became an issue of how are you safe and integrated in it. So eventually we decided to do a Surface Pro on a stick, and we use the Teladoc InTouch at the time, now Teladoc platform, because it had the best connectivity in our experience. The next thing is foundation support. How did we pay for the neurologist's time? Neurology a lot of times makes money from E&M codes. We don't have a lot of procedures, especially neurohospitalists don't have a lot of procedures, but a good 50% or more of salary is covered by what you bill and how you see it. FAST Act did approve Medicare reimbursement, but it only approved it at the time for the Medicare G codes. And the G codes were written in such a way that they were maybe an eighth or less of what your E&M would be if you were in person seeing the patient. So here you are doing an equivalent care. We know that it's equitable care, and yet you're getting a significant decrease in reimbursement. And so we had to decide at the time, how are we going to support our neurologist, knowing that the way we would support them in the hospital didn't actually work. We also wanted our neurologist to have an expectation of being present within 5 minutes of being alerted. Presence for us is at least an initial phone call to be part of it, and then a lot of phone screening that then turned into video visits for final assessments, patient discussions, and evaluations. But within 5 minutes, we wanted to be able to be part of that team. And that means the neurologist can't be seeing clinic patients, they can't be rounding in another hospital and in the middle of a different stroke code that's going on. And so we really wanted them to have dedicated time. We ended up developing a cost sharing model that was a fee for each facility based on the cost of the equipment they needed, flat rate of their ED volume and hospital bed analysis for stroke volume that we adjusted on an annual basis. As a system, we moved away from a per call cost, because what we found in a lot of our spoke facilities is if you paid for a call, even if the physician wasn't even aware of how much the pay per call was, it set up a mindset of, we're going to wait and do an assessment before we call. And that time, that delay, was leading to lengthy door-to-needle times. The next step is local buy-in. So how did we get people to want to partake in telestroke? A lot of our facilities, again, rural areas where the emergency room physician has been doing it for a long time on their own. A lot of hesitancy in our areas for even giving TPA, and definite hesitancy for having a neurologist or a video neurologist come in and help with part of the process. We went about it slowly, with a culture of collaboration, a constant discussion of how is the process working, how do we blend it together, how do we support the emergency physician and being the ultimate decision maker here, with us suggesting and collaborating with them. And then along with it, defining what was the quality need, what was the current quality we were seeing in their facility, and what did we think we wanted to do as a goal of the next quality with it. Along with it, then we came up with our target quality metrics. In reviewing all the different aspects of what to look at, we decided it was easy to be simple, straightforward measure. You couldn't measure more than 3 things before administrators and teams got bogged down in it and you lost responsiveness and ability to change. Target Stroke came out and showed that there was a reduction in in-hospital mortality and long-term disability with the 15-minute improvement, which just further helps support that door-to-needle time was going to be our leading metric that we looked at for our facilities. We aligned it with the initial AHA Target Stroke because we created this before the change in door-to-needle recommendations, with door-to-needle of 45 minutes or less for 50% and 60 minutes or less for 75%. We also got a super user account, which allowed for us to pull at a system level what all of our facilities were doing. However, it also gave the facility the feeling that it was their data, their quality. It wasn't somebody pulling things that weren't relevant, and they were still actively involved in the process improvement with it. And so this tool ended up being really important to us on how we continued that sense of collaboration as we went through this process. The next thing was aligning protocols. So again, every facility had some differences, but there are things that we know really improve door-to-needle times in care of stroke patients. Nurse activation being one of the really key ones. And with nurse activation, that still today is one of the hardest ones for me to continue to support, and that I have a lot of nurses that get timid about it. Sometimes I have physicians that feel that it's a waste of time and that they should be called in to make the assessment. But we've done numerous reviews at our different sites and been able to show continuously, if you have a good nurse activation criteria and you have support for that nurse to activate, even if we end up canceling or saying the patient isn't a candidate quite quickly, it really improves door to needle times in the patients that we treat. And it empowers the team and the frontline triage nurse as part of our team to really own what happens to that stroke patient and the emergency around it. The same thing with straight to CT for our stroke activations. At every one of our facilities, we help them work through how do they do that process. And then Telestroke, we asked that Telestroke was activated when the patient arrived and the nurse activated in triage. And that way we were virtually there and part of the team and process as we continued to take care of those patients. We aligned on our activation symptoms, which there can be a wide variety of what people think are stroke activation, and we aligned on it and have continued to improve that over time. And then the other key thing, especially in our rural facilities, was teaching the concept of parallel processes. You know, when you're at a big comprehensive center, you get very used to parallel processes and how that works. And a lot of times our smaller centers, because they don't have that volume, because they're not used to that fast pace and dynamics, it's a process to kind of teach. How do we have parallel processes? How do we check as many things are happening at once, and really help set that mindset for treating a stroke patient? In our first years of Telestroke in Central to Texas, we were slow to roll it out. This is over 1.5 years. It took us to get to 7 facilities. Several of them were rural facilities. And we gave time. We gave time for each facility to come on, to be ready. We also gave time in that we did not add more facilities until we had faculty that could help cover it, so that we didn't drop quality at any point in time. As you can see, though, when you start to open the door, it can grow quite quickly. We had a poster presentation in 2020 done by one of our stellar residents that really looked at the first 6 months before Telestroke and after Telestroke in these facilities. Again, majority of them are rural facilities, to say, in 6 months, could we actually improve door to needle time? And we found that we did. That with statistical significance, we brought more patients into less than 45 minutes and less than 60 minutes. You might say that it's related to increase in TPA. There is a slight increase in TPA, but it didn't meet statistical significance. And so it isn't that it's just more volume. It was actually an improvement in that quality process and that integration from our spoken hub stroke process. In dealing with administrators, a lot of times, and how do you fund it, and what is my benefit that I'm getting from Telestroke outside of quality, which quality to me is always the most important thing, because as a neurologist, you're here to treat the patient and make sure they have the best outcome. But another one is, how are you growing neurosciences? And I often get that question. So we looked at it to say, as we developed Telestroke, did it actually make a difference in our complex stroke that came? Did it make a difference in our complex ICH cases, our hemicranie cases, our thrombectomy, our subarachnoid cases? And found that it did. And in fact, it made such a difference that even during COVID, it sustained as a difference for the transfer pattern that was associated with it. We did need a high volume. We needed about 50 Telestroke alerts for one additional case to be sent to our comprehensive stroke for Central Texas area. And so when you look at what do you have to invest to get those higher paying cases and the more complex cases that the administrators often ask about, it is quite a few alerts and patients that you're reaching out to and increasing access to care to then have the complexity come along with it. So we systemized care, we proved quality in the Central Texas results, then went and sold that to our system leadership. And for those of you that know Baylor Scott and White system or don't, we have a North Texas area, which is a Dallas Metroplex non-rural area. And then Central Texas, as we described, is our rural area. And that's where our program started. And we were able to demonstrate, though, that there was such a benefit to Telestroke and such good quality metrics that were coming out that we got approved for it to be spread throughout the system and to become a standard in Baylor Scott and White. Along with that, we actually integrated all of our neurologists across the system, and we have 4 sites that had in-person neurologists. And all of them have a portion of their time now that they cover Telestroke for the entire system. And so we've become a collaborative team. We have weekly stroke alert case reviews to look at quality and patient outcome and talk about the nitty-gritty details of how stroke and our treatment ideas and how all of it went. And it's created a robust team to treat these stroke patients across all of these hospitals, as opposed to before in Central Texas, where there was maybe 2 to 3 people and one person got sick or had a baby or moved for some reason, and the whole program felt like it was going to fall apart. Now with this whole system integration, we've got 13 and about to be 18 neurologists that participate, and we've hit that kind of robustness that we can care for our patients and allow for the things that happen in life to happen. We also continue to use the Get with the Guidelines super user to pull centralized data, create system scorecards, and have several steps in the future to how to keep continuing to push this process. Here's an example of our scorecards, and I'm sorry they're so small. I hope that you guys can see them. If you look here, this is for fiscal year 2018, 19, 20, and then 21. And the dark blue are places that we already had Telestroke. Light blue, Telestroke was starting. And as you can see, as a system, we had a lot of reds to start off with. And then we started to get more green, and definitely green in our Telestroke facilities. And then as we went on, more green, even non-Telestroke facilities, because the more you start looking at something and reviewing it, facilities start trying to figure out how to help as well. And then in fiscal year 2021, which is also when COVID hit, we had just gotten pre-approved to move to those new door-to-needle times of 45 minutes at 75% and under 60 minutes at 85%. So you'll see some orange here at people that met the old criteria, but not the new criteria. Overall, we saw a huge improvement in our door-to-needle times across the system. And you can see here in COVID, we had a dropout in our percent treatment in TPA, but my understanding is that was more of a national issue than a specific issue to our facilities. Along with that, we have created several councils through our organization. We've got a stroke advisory council, which has physician, nursing leadership, and administrators participate so they can learn about the process, but it's really driven by our leaders. It's an interesting group because we have representation from all of our hospitals, but in different areas of specialty. We've got PM&R specialists from some facilities. We've got neurosurgery from others, neuro-IR, hospitalist, neuroradiologist, and stroke neurologists. So across the group in neurocritical care. So across different facilities, different specialties, it kind of helped us break down the idea of any sort of barriers to what a certain facility wanted and look at, we're all physicians and nurses that want top quality care, and how do we standardize and how do we talk about evidence and start creating protocols and standards that meet the betterment of all of our patients. It took a while to get that to work and for people to stop just looking at their own hospital and their own perspective. But now I think it's quite robust, and we have a lot of really good work that comes out of the group. Along with it, we have a system stroke coordinator council, which every hospital that has a stroke coordinator participates in it, and they're working through actually how to standardize where abstraction happens. As I said earlier, the Get with the Guidelines was nice. The super user was nice because we could pull what the each facility was doing, and it was their data that then got represented. So it wasn't that we were skewing or changing it at a central level. What we had found, though, is that several of our sites have different ideas of where to pull abstracts and data. And so our council is now working on how do they define it? How do they want to continue to define an improvement? And how do we really standardize that across the system so that we're comparing apples to apples when we look at the data? And that's for all of Get With The Guidelines, not just door to needle time. If you look at the outcomes of implementing Telestroke across our BSW system now, so North and Central Texas, because we rolled into fiscal year 20 is when we started really developing it throughout, actually fiscal year 21 throughout the system. You can see that with Telestroke present, we really started to improve our door to needle times, where we're almost 100% less than 60 minutes. And we're definitely, as a system, above 75% less than 45 minutes. We work as a system to also help the facilities that are lagging behind to figure out why and how we can improve it and what process aspects are there. We do not in any of this data have a punitive approach or talk about not funding or not supporting facilities that aren't quite making it. It's much more of a collaboration of what can we do, how can we improve it, how can we as a team move the quality forward. The other key thing that happened with the integration of our neurologist and our Telestroke between the two systems is actually we centralized our transfer process. And that seems like something small, but it actually has been huge, especially during COVID. What that meant is that any patient that came to our BSW facility during COVID, we were able to still treat them for their complex stroke, for their endovascular stroke, for their TPA related. And if that facility they arrived to was at capacity, which as you guys all know, in COVID, a lot of our facilities were at capacity. A lot of Texas was not taking endovascular transfers, and we were transferring out of the state of Texas. We were able to keep all of those patients within system, maybe not to their hub that would be preferred, but they could go to one of the 3 hubs. And because it was a centralized neurology group that was working for stroke, we always knew which hub was open and how to help get them with the transfer center to where they could get treated. And I'm proud to say that through all of COVID, we only had 1 endovascular patient that we couldn't treat at one of our facilities. So, you know, I wish we could have done 100%, but only losing 1, I'm pretty proud of that actually. So downstream effects of everything, you know, a rising tide lifts all boats. What we were able to show is that competition between facilities really didn't benefit us as far as, you know, people wanting only their facility to grow, that as we grew as a system and we started viewing things as a system and network, all of our hospitals improved and benefited. In the data I showed you, we didn't include any of our hub statistics, but our hub centers saw a huge reduction in mortality as we started improving integration of care and really the leading metric of door to needle times to get patients treated faster, whether it's at a spoke facility or at their own facility. We saw a reduction of symptomatic ICH across the system, and we now have very few deaths ever related to it as well, because if there is a change in an ICH noted, you have a telestroke neurologist that is available and acts very quickly to be there and be present. And then we continued to have that ability to share complex treatment even when we were at capacity and didn't have many beds available. On the horizon, what do we see next? And I warned Deb that this may be a quick lecture, so I guess we've got lots of time for questions in a second. Door in, door out is definitely the next key metric that we as a system will be looking at. We actually had to suspend it during COVID because of the bed shortage. It just wasn't fair. It wasn't fair to look at our system and look at our processes when there was nowhere to transfer patients and non-urgent patients too. But that metric will start this year. We're standardizing our Get With The Guideline abstraction, first determining where we want to get it from, and then we're also, for portions of it, going to have our own internal central abstraction group to abstract it. We created a stroke coordinator infrastructure and are in the process of finalizing it. And this is near and dear to my heart because I have worked with some incredible nurse stroke coordinators over the years and lost them because there was no career path or promotion path available. And so we have been able to really start looking at how do we give that promotion path available? How do we create an infrastructure where their leadership and expertise is recognized and empowered, and they're part of our care team. We're also developing Telestroke scorecards, so data on, how's the stroke process working for your facility? How are our stroke neurologists and their outcomes? How is feedback? How are endovascular specialists? We're going to do it as well for them so that we have feedback on our quality metrics, both to our providers and to our facilities. So our lessons learned, I think one of the most important things was the contracted care or contracted cost of facility so that our neurologists could be given the freedom to really take care of the patient, be timely, and spend time integrating and knowing their spoke facilities and helping improve the process there. Investing in local support and being activated right away as the stroke was activated was very important. We had other sites that had done spokeless telestroke before they became part of our system telestroke. And sometimes they waited an hour or more to call their telestroke group. And in doing that, how can you make any of your door to needle times? You just can't. So being present as if you were there in person, running down to that stroke code was really important to us. We got local buy-in and collaboration through service, continual discussions of how can we improve our service, and our stroke neurologists really focus on being patient-oriented and service-oriented for all of our facilities. Quality matters. Having metrics to show success was really important. It got us buy-in from leadership. It gets us satisfaction to see the outcome of what's happening in the patients that we care for, because in a telestroke evaluation, it's a very short evaluation. And it also growed our intervention cases and our complexity. Just for perspective, this is our telestroke network for 2021. So this is our Central Texas Temple and all of our acute stroke ready going into PSCs and then to our CSC. And in the Dallas area, we have 2 large CSCs that have more primary stroke centers and not as many acute stroke ready because they don't have the rural area that feed in. And here's our wonderful telestroke team. Any questions?
Thank you so much for your presentation. It's amazing. I mean, I love the story, your whole story of how the development of your stroke program was, and the outcomes that you've achieved is amazing. So let me look at our chat box. Please, anybody who has questions, type them in the chat box and I will ask them. And we have a couple here right now. So my first question is, are you also tracking how many times TPA is recommended but the ERMD does not order it, since ultimately it's the ERMD's end decision to order?
We have never had that happen.
Oh, that's awesome. Okay, next question.
But I should say we do joint consent. So we consent the patients and the ER physician is part of it. And any disagreements that we actually have on a private phone call before we go in to consent the patient. So that's part of building the collaboration, is how do you build that discussion and that safe place, not in front of a patient, to have the discussion.
Okay, thank you. Next question. You mentioned one of the downstream effects was decreased in hub mortality. What has happened with stroke mortality during this process?
So I don't have access to see overall stroke mortality for the system yet. That is another one of the ones that we want to start pulling in. I am part of several hub mortality groups, and that's where I can say that the reduction in door to needle time and the support of telestroke to get the patients transferred quickly has reduced it. And it is reduced at several of our hubs. We were it's an odds ratio where 1 is, as many observed or expected. And some of our hubs were actually above 1. And then with working on and administrative support on improving door to needle times, most of our facilities are now at like 0.8.
Wow, that's great. I don't see any other questions. Anybody else have any questions or comments? Well, I don't want to make sure I didn't miss one here. Oh, here's one. How do you suggest getting the activation of telestroke in the ER quickly? Also, connectivity tends to be an issue, especially in CT area. Thoughts?
I think part of your page out should just page your telestroke group immediately. And that comes with an understanding of, we know that we're going to get overactivated, and we know that if, the nurse activates and then the physician comes in there and it's different, or they talk to you and it's different, it's okay to just say, okay, this one we're passing on and we don't need to treat. And I think creating that culture of where it's okay to overactivate, especially within the framework that you have decided is your activation criteria, is really important, because as soon as just the smallest punitive happens, a neurologist is cranky and gets cranky with an ED physician, an ED physician's cranky and gets cranky with a nurse. One small instance can actually set you back for months. And so it's important to continually reinforce that culture of collaboration and putting the patient first. I think there was another aspect to that question that I didn't answer. Deb, will you remind me?
Yes, it's how do you suggest getting the activation of telestroke in the ER quickly? Also, connectivity tends to be an issue, especially in the CT area.
I have not been able to have good connectivity in the CT area. And so sometimes I may not actually see the patient on video, but I'm on phone with the ER provider and looking at the images, and we're making a joint decision that way. And then I see the patient after the bolus has been given. I have another, one of my mid-sized facilities actually won a quality award through BSW. The nurse there figured out that there was a door off of the CT scanner that went into this empty room that was just storage was being put in there, and suggested, why don't we make it a stroke room? And so they cleaned it out, they put a bed, they actually put an extra Wi-Fi unit in there to make sure that it had good connectivity. Robot went in there, and then the patient could go straight from CT into this room. We cut down on transport time, and they've got some of the best door needle times of our system now.
Nice. Another question. Any tips on increasing triage nurse activations of stroke alert and MD buy-in?
I think it has to be double pronged. You have to have a stroke coordinator that helps get the nurses feel empowered and gives positive feedback to them when they activate. And maybe a little bit of, hey, maybe you should have activated, or what are your barriers? And you also need the physician leader, your stroke director, whether that's an ER stroke director or a neurologist stroke director, to be involved and bought in so that they can give feedback to the physicians to say, hey, why did we delay an activation? Or, hey, why aren't you empowering your nurses to do it? Look at the numbers. Several of our facilities that really did not want to do nurse activation, and they did it and then they slid back and then did it again. We were able to show it actually increased 15 minutes on average for the facilities if we had to wait for a physician to weigh in on it and activate. And think about, we know that makes a difference in mortality and outcome. And so when you start having those discussions, I've found that physicians want to do what's best for the patient and accept the fact that there may be some overactivation.
Okay. Another question. Does the same activation process apply at any freestanding ERs or urgent care clinics associated with your system?
We only have one ER that acts like a freestanding ER, and yes, it is the same activation criteria and same process.
Okay. What about your in-house strokes? How do you treat the in-house stroke population?
So in-house stroke is really tricky. And it's tricky because If you have a low volume or rural center, then you don't have that nursing expertise to help you through with, is the patient safe? What are you going to do? Should you treat? And so for our process, we actually require that physicians are part of it in-house, either the hospital, not physicians, it could be an APP as well, but the hospitalist that's there, or some places that don't have in-house hospitalists, the ED will help us as well. And that they have evaluated and screen the patient before calling us. And the reason is really around safety. When you have somebody that's admitted for stroke or TIA or other reason, and they have new onset stroke symptoms, there are so many drugs and things that can be going on that are unsafe that without another lead provider there, you can miss. For example, I had one time when I was trying to do it myself before we had put in that we need a hospitalist or someone in-house to be part of us. I had had great discussions with a lead nurse who was with me, and we're assessing and getting ready to treat this patient with TPA. And it was, and I get on video and consenting the patient, and then I saw something running in the background. And again, when you're on Telestroke video, you're only limited to what's right in front of you. And so something in the background, you can't go and look at it like you can in person, or zoom into it necessarily as easily. And if it's not in your view, you can't see it at all. And I said, what is that running? And the nurse said, well, it's heparin. And I said, what do you mean patients on heparin? And they're like, yeah, you know, when they first started having symptoms, they were concerned. And so we started a heparin drip, but it hadn't been ordered or placed in the EMR for me to be aware of. And it wasn't brought up as an important aspect. And I was about to TPA the patient. And I wish that was an isolated example, but I've had similar examples at different facilities along that lines. And so I think for patient safety, an inpatient alert is something different, and it really needs another lead provider, be it an APP or physician, to collaborate with Telestroke just to make sure those patients are safe.
Thank you. I'm not seeing any other questions. Does anybody else have any questions they would like answered? Please type them in the chat box. All right, and with no other questions at this time, I just want to take the opportunity to thank you so much for sharing your knowledge and expertise. This was a great webinar, and I think a lot of people will be able to benefit from the lessons learned at Baylor Scott and White. Oh, wait, we have one more. One more. Do you have experience with clinic telestroke and have any tips for that process?
I have found that clinic telestroke does not work, because how can you, right? Because in clinic, what you're doing is I should step back. Do you mean outpatient neurology providers who are also giving telestroke coverage? Or are you meaning teleneurology as clinic virtually seeing patients?
Can you clarify that, Jennifer? Clinic telestroke and have any tips for that process? Oh, outpatient neurology providers for follow-up on stroke patients.
Oh, I think having a transition to care clinic is vital to a good stroke program. And whether that be virtual or in person or a hybrid, I think it is incredibly vital. And we actually have a clinic in Temple for that, in which the patients are seen within 7 days of discharge to home. And for a while, especially during COVID, they actually saw patients for several of our rural hospitals as well virtually. And we saw a reduction in readmissions and improvement in patient blood pressure and control. I think it's a vital program, and it actually reimburses well, because you get a transition to care clinic, billing charge with it. So hopefully, if there's anybody still on and listening, hopefully we ask CMS to approve permanently the extended COVID telemedicine criteria, because I think it's been such a benefit to our patients to be able to have access to providers and not have to take 2 to 3 hours out of their day, especially our stroke patients. And while we're protected for telestroke, to have it approved and paid for all of neurology, stroke follow-up clinic, teleneurohospitalist, I think is going to be very important for the care of our patients. That was my soapbox for a second. Thanks for letting me say it.
Oh, thank you so much. So I'm not seeing any further questions, but there are a lot of comments thanking you for your presentation and saying it was very informative. So we really, really appreciate your time and expertise, and have a great rest of your day, everybody.
Thanks for having me.